Hello, my name is Christina Traber, and I'm a geriatric nurse practitioner with the SLU Division of Geriatric Medicine. And today we will be talking about hypertension in older adults. And this is part of a project supported by Health Resources and Services Administration and the Geriatric Workforce Enhancement Program grant. So today, we will be talking about hypertension, how the diagnosis and treatment of hypertension differ in older adults, when to recommend lifestyle modification, how to choose among the various classes of antihypertensive agents, and the principles of adjusting therapy. So we know that systolic blood pressure increases progressively with age. However, diastolic blood pressure plateaus in about the fifth or sixth decade. And according to the National Health and Nutrition Examination Survey from 2011 to 2012, about 65% of non-institutionalized adults over the age of 60 had hypertension. And over the last few decades, awareness and control rates of hypertension have improved significantly. The number of adults over the age of 60 who were aware of their hypertension was about 86%. And the number of those receiving treatment was close to 82%. And about close to 50% of elder adults actually have their hypertension controlled. Increased systolic blood pressure is associated with cardiovascular, cerebrovascular, and renal disease, and it may also increase the risk of age-related cognitive decline and cognitive disorders. And many factors contribute to poor rates of blood pressure control, including lack of awareness of having hypertension and misinformation. These issues appear to be particular barriers among older Black and Hispanic women. Factors related to healthcare providers' practices and concepts about hypertension in older adults also contribute to the age-related disparities in control rates. So age-related changes, we know that arterial thickness changes, which equates to increased vascular stiffness and equates to a higher blood pressure overall. This increased peripheral vascular resistance and causes decreased vascular compliance. There's also an age-associated decline in baroreflex sensitivity and also changes in the sympathetic nervous system. And because of the blunted sensitivity of the baroreflex, a greater decrease in blood pressure occurs before heart rate increases and other compensatory mechanisms are activated, which can cause more orthostatic hypotension issues. There's also changes in the circadian control of blood pressure, which predisposes older adults to higher relative nighttime blood pressure and greater early morning blood pressure rise. And these can both lead to increased risk of stroke and MI. In addition to the increase in blood pressure level, blood pressure dysregulation in older adults puts them at higher risk, again, for the orthostatic and postprandial hypertension. So changes in kidney function and systems involved in sodium balance also lead to increased salt sensitivity. So lots of different changes with both issues with controlling both high blood pressure and then changes in position, specifically after meals and medications. So due to this blood pressure variability, diagnosis requires at least 3 blood pressure readings taken on 2 separate visits for a diagnosis of hypertension. And we should consider ambulatory blood pressure monitoring for patients, especially those that have extreme blood pressure variability, those that possibly have white coat hypertension or have hypertension only when they come to the doctor's office due to anxiety, or those who are concerned for having hypotensive episodes. So let's talk just for a minute on how to correctly take a blood pressure. And this is taken from the actual American Heart Association. And it's pretty complicated and probably not how we typically take blood pressure in clinics or in long-term care. So to correctly take a blood pressure, the patient should avoid caffeine, alcohol, tobacco, and exercise for at least 30 minutes before. They should sit with their feet flat on the floor, rest their back against the chair, and place their arm on a table or other flat surface. Then they should sit quietly for 5 minutes, wrap the cuffs snugly around the upper part of the arm, the bare arm, so no clothes. Then they would ideally, you would measure your blood pressure in both arms when you first start and always use the same arm thereafter. You should take readings at the same time each day and don't round your measurements up or down. Don't worry if you get an unexpected high reading or about a small change. And don't check your blood pressure too often because it can make you anxious. And also don't stop taking any medications if your blood pressure falls. So I don't know about you, but most of the time when we take blood pressures, I don't think people are waiting 30 minutes. They're not sitting quietly for 5 minutes as well. And they're probably not sitting with their feet flat on the floor with their arm on a table. So not always taken exactly accurately. And then this is just the same information, but in picture form. So again, take at least 2 readings 1 minute apart in the morning before taking medicines and in the evening before going to bed. So in an ideal world, this is what it would look like. So clinically, once you see that there's someone that's been having issues with blood pressure, we're going to exclude secondary forms of hypertension. And although most hypertensive older patients have essential hypertension, secondary forms of hypertension should be suspected in the presence of malignant hypertension or a sudden increase in diastolic blood pressure, a new worsening level of blood pressure control, or resistant hypertension, which is described as a poorly controlled blood pressure on a regimen of at least 3 antihypertensive medications, including a diuretic. Renal vascular disease is the most common secondary form of hypertension, as well as hyperaldosteronism, obstructive sleep apnea, and use of NSAIDs. Then we want to identify if there's been any target organ damage, determine if they have any cardiovascular disease risk factors, and identify comorbidities. And we want to inquire about their lifestyle. Are they a smoker? What's their dietary intake of sodium and fat, alcohol intake, and how much physical activity they have? There are medications that are known to increase blood pressure, specifically steroids, decongestants, nonsteroidals, erythropoietin, and mirabegron, to name a few. And we know that there's a benefit of treatment. So someone who has true hypertension, a treatment reduces overall mortality, cardiovascular events, heart failure, and stroke. However, what is considered the correct blood pressure to control an older person to? And that's where the literature gets a little sticky. This evidence is not as consistent in those over the age of 80, which is a large portion of our population, especially in long-term care. But I do want to spend a little time talking about a couple of different studies that have attempted to answer this question. The first being the hypertension in the very elderly trial, otherwise known as HIVET. This study was showed to decrease mortality in those older than 80, but did not include frail or very old individuals. So again, this study was completed in 2007. It was a randomized controlled trial of just about over 3,800 participants, and they were over the age of 80, with a mean age of about 83. It was done in 195 centers in 13 countries. And in the active treatment group, they were, and the placebo group were well matched, with an average mean blood pressure sitting of 173 over about 90. The treatment group was given 2 medications that we don't really use in the States, but indapamide plus paridomipril, or another ACE, if needed. And the goal was to achieve a blood pressure of 150. So again, not too low. 150 was their goal from 173 average. And at 2 years, they found that the mean blood pressure while sitting in this active treatment group was about 15 points systolic lower. So if you go back to the 173, that puts them almost to the 150 goal, 150s, at least in that range. They also found that the active treatment was associated with a statistically significant, a 21% reduction in the rate of death from any cause. It also showed reductions in lots of other items, including stroke and MI. They actually ended this trial early because of the significant 21% reduction in total mortality in the active group. It is important to note that the participants in this trial were generally healthy community dwelling. So even though it was older people over the age of 80, it was not done in a long-term care setting. It excluded those with dementia, those living in nursing homes, or an ability to walk. And that's very common in not only this study, but several of the other studies that we'll talk about later. So these are some of the graph pictures from the study. So again, systolic blood pressure in the placebo group, it showed a little bit of reduction, but it was still over that overall goal of 150, while the active treatment group, according to this, kind of all within that 2 to 5 years all hit that goal. But again, we're not talking about getting someone's blood pressure down to 120 or even 130. I would say maybe 140s to 150s is kind of where all of those are, and 80s for diastolic. And again, statistically significant from all death from any cause right here in the placebo versus the active. But also all of these things were better, heart failure including. The other kind of popular study that's used a lot of time for hypertension in older people was part of the SPRINT trial, so the systolic blood pressure intervention trial. And so this study took about 9,300 adults age 50 and older, so not all geriatric, and it looked at lowering the blood pressure to 130. I'm sorry, let me go back up. It looked at systolic blood pressure of 130 or higher and at least one other cardiovascular risk factor. So these were people that already had cardiovascular risk. Enrollment occurred outside of the United States, including Puerto Rico, or in the United States, including Puerto Rico, and only about 28% of these patients were 75 and older. So some, but not very many. And this was a pre-specific subgroup analysis of those over the age of 75. And it included looking at an intensive treatment target of a systolic blood pressure of less than 120. And what it found was in that intensive treatment arm, there was about a 33% relative risk reduction in composite outcomes of fatal and non-fatal cardiovascular events compared with the standard treatment of 140. So it thought it was part of the new ACC, American Cardiac and also American Heart Association guidelines that define high blood pressure for adults as a systolic reading of 130 millimeters of mercury or higher, or a diastolic reading of 80 or higher. Again, the average blood pressure in the treatment arm was 123, even though their goal was 120. And again, it excluded diabetics, stroke, dementia, and nursing home and assisted living as well. So the JNCH, the Eighth Joint National Committee, most recently released evidence-based recommendations are as followed. It's for blood pressure for those over the age of 60 overall to be less than 150/90. It specifically says that an acceptable target of less than 140/90 and no adverse effects or health or quality of life would be the target as well. Diabetics and renal was also a subcategory that they believed also should be less than 140/90. And systolic blood pressure is a strong predictor of adverse outcomes when over diastolic. And so target blood pressure of less than 150 has been questioned recently in light of the results of the systolic blood pressure. So even though that's what the Joint National Committee is saying, because of trials like the SPRINT, there are some people that are still saying, well, maybe that's still a little bit high given the reduction in cardiovascular. So again, over the age of 60, target range is 150/90, less than 60, 140/90, renal and diabetes, 140/90. So lifestyle modifications are important. So they're an adjunct to drug therapy for all hypertensive patients. It includes weight reduction for those that are obese, increased physical activity, a reduction in stress. A reduction in sodium intake is helpful, and an increased intake of potassium in the forms of fruits and vegetables. So, in the randomized trial of non-pharmacological interventions in the elderly study, it evaluated the effects of dietary sodium restriction and weight loss in older adults, and it demonstrated that relatively modest reductions in dietary sodium intake, which was about 1.8 grams a day, and in body weight of about 4 kilograms, were accompanied by about a 30% decrease in the need to reinitiate pharmacological treatment. And a meta-analysis of randomized trials assessing the effects of dietary sodium restriction demonstrated a significant reduction in systolic blood pressure, a mean decrease of about 3 points for each 2.4 grams a day of sodium, but not in diastolic. So the differential reduction in systolic blood pressure is particularly well suited for the older hypertensive patient. So with that said, we tend to be a little bit more liberal with our diets and we don't want to restrict sodium. But if we do have someone that is eating a lot of sodium, a mild reduction does show to help with blood pressure. So generally, treatment guidelines for hypertension is to try to begin with a non-pharmacological approach if possible. We're going to base the drug selection or combination therapies on the individual patient characteristics, which we'll talk about a little bit more in a second. Where typically you would use a low-dose thiazide type diuretic, calcium channel blocker, an ACE, or an ARB as first choice. Remember, when starting drug therapy, as on all elderly, we're going to begin with the low dose. So sometimes half the usual dose, increase slowly, continue the non-pharmacological therapies. Treatment goals should be gauged by how the systolic blood pressure is doing and also based on the patient's comorbidity profile. And we're going to try to avoid excess reduction in diastolic. So again, diastolic is not really what we're trying to treat as much as systolic seems to be more important. And we definitely want to avoid having diastolic blood pressures less than 60 to 65. Initial drug choice is influenced by the presence or absence of comorbid conditions. So diabetes, coronary artery disease, heart failure, also cost and compliance also feeds into that as well. Medications should be started at the lowest dose, which is said, and they should be adjusted during follow-up visits of about every 4 to 6 weeks. So a little bit of time in between there so that we can see the response. Typically, thiazide type diuretics or calcium channel blockers, and ARBs and ACEs are all effective as initial treatments in non-Black. In Black older adults, we find that thiazide type diuretics or calcium channel blockers tend to be preferred. So just kind of touching on each of these choices, I said diuretics significantly benefits in mortality, stroke, and cardiovascular risk profiles. Adverse event profile includes mostly electrolyte disturbances and more likely with higher dosages. Potassium replacement may be important. So loop diuretics are usually reserved for patients with either CHF or CKD. And then ACE inhibitors, again, can be used as initial monotherapy for hypertension. Most common adverse risk or event profile would be cough and hyperkalemia, angioedema. And they're particularly advantageous for patients that have diabetes or CHF. Angiotensin blockers are used as also as first line, especially with those with diabetic heart failure or microalbuminemia. It's also an option for patients who cannot tolerate ACEs. Calcium channel blockers we use at kind of lower doses. The main adverse effect I see with them is more edema related and postural hypotension, constipation. Other classes we sometimes use, we use alpha receptor agonists at times, like doxazosin or tamsulosin. They're not usually appropriate for first line hypertension, but often used as part of a multi-drug regimen. Direct vasodilators like hydralazine and minoxidil are usually considered last line due to tachycardia and arrhythmias. Clonidine or other centrally acting agents are usually poorly tolerated. They usually cause more sedation, bradycardia, and have an issue with reflex hypertension, and tachycardia if they're stopped. So we tend to shy away from them. Alpha beta blockers typically labetalol is mostly used just in hypertensive urgency, and carvedilol is used in heart failure. So like I said, follow-up visits, usually after starting a medication, we would want to wait about 4 to 6 weeks. And we're going to follow up to assess the adherence to therapy, monitor for adverse effects. We're going to measure for postural hypotension as well as so measuring supine and standing. We're going to encourage blood pressure monitoring outside of clinic. So they're going to go home hopefully with a cuff, or you can always go to the grocery store to get your blood pressure checked as well. Adjust doses cautiously, reinforce lifestyle modifications as indicated, evaluate for refractory hypertension. And then again, attempts to reduce blood pressure to target levels too rapidly are often unnecessary and likely cause more hypotension and issues with that. So in general, 4 to 6 weeks between visits. And it may take up to 10 to 12 weeks for full pharmacodynamic effect after starting a med or increasing a dose. So again, trying to go as slow as possible. Adjusting therapy, again, when blood pressure has not been successful, then we cautiously will increase the dose. We may add another med, and particularly a thiazide type diuretic, or we may switch classes. If a blood pressure target is not attained after being on a 3-drug regimen, we're going to evaluate that patient for refractory hypertension. And eventually, after we kind of get things stable, we can consider stepping down treatment once the patient has been maintained target blood pressure for about a year. Just want to talk a little bit about hypertension emergency versus urgency. So hypertension emergency is described as a vascular compromise of vital organs due to extreme blood pressure elevation. So it would equate to having hypertensive encephalopathy, pulmonary edema, and aortic dissection or unstable angina. And management of a hypertension emergency would happen in an acute hospital where they're getting IV medications of antihypertensives, and they would initially target a gradual reduction in blood pressure over about 6 hours. So not trying to get to a normal blood pressure too quickly. So do not lower blood pressure more than about 25% within the first 2 hours. This is different than someone who comes into your clinic office, has absolutely no symptoms, and has a high blood pressure. That would be considered hypertension urgency. They have a high blood pressure. They're asymptomatic. They come in routine and that you find it. They need to be treated with oral medications, but they don't have to be sent to the hospital unless they're having some kind of symptoms. So in the long-term care setting, hypertension affects about 30 to 60% of residents. They also have a lot of postprandial hypotension. So about a third of them also have hypotension. And this is an independent risk factor for falls, syncope, stroke, and mortality. So management of hypertension in long-term care, again, we're going to look at these patients carefully. These are going to be over those patients that are not studied in any of the studies, they're eliminated. So we're not really sure what exactly the right target is. And they tend to have as much trouble, if not more, with low blood pressure issues as they do with high. So it's trying to find that sweet spot for them. So risk-benefit ratio of treatment is unclear due to patients' advancing age, the patients with multiple comorbidities, and they're often already taking multiple medications. And while some studies suggest that avoiding aggressive blood pressure control less than 130 is likely safer in this population, which we believe. Several studies have also identified antihypertensives, as particularly vasodilators like hydralazine, as a fall risk factor in the population. So a lot of fall issues with these medications. So just want to touch on one more study. This was a study done, the PARTAGE study, or predictive values of blood pressure and arterial stiffness in institutionalized very aged population. So this was a longitudinal study, multi-centered, looked at about 1,100, just over 1,100 frail individuals greater than 80. So, I mean, that's good. It showed a significant increase in mortality in those receiving more than 2 antihypertensive medications and a systolic blood pressure below 130. So again, it reiterates that although the SPRINT trial showed that it was good for those with heart disease to have low blood pressure, this population avoiding a systolic blood pressure less than 130 is likely to be safer. So going back to the GNC8 guidelines of 140 over 90 for those with diabetes or CKD or less than 60, and maybe 100 up to as high as 150 over 90, depending on other comorbid conditions, seems to be where we are at with evidence base. Again, just making sure that we know how, just like we know how to check a regular blood pressure and how we're supposed to do that, how we're supposed to check orthostatic blood pressures. So sitting to standing, sometimes laying to standing, waiting a minute after they stand, and it's defined as at least a 20 milligram of mercury fall in the systolic and a 10 fall in diastolic. They often have symptoms of cerebral hypoperfusion, so enough to make a diagnosis. So when they stand up, they say, I stand up and I get dizzy, done. Like that's what's going on. So commonly what you would tell them is they're going to stand up, they're going to give it a minute, and they're going to give their body time with those age-related changes and then increased stiffness and all those things we talked about from the very beginning to catch up and get that blood flow to their brain, and they should be okay then to continue. The problem you have is with those people that get up and just start going, and the room starts spinning because they just haven't given themselves that adequate time. This is super common with people that have Parkinson's, of course. So just really watching them, and this is prevents falls. So I mean, this is a very common reason to have falls. So again, as important it is to check their sitting, blood pressure and their systolic is high, we have to also correlate that with what they're doing when they're walking and standing, and if they're having issues with orthostatic blood pressure. So in summary, treatment of hypertension reduces the risk of cardiovascular disease, events, and mortality. That's true. Lifestyle modification is recommended. First line drug therapy can include any antihypertensive class for the most part, except beta blockers and non-cardiac patients or alpha blockers. The whole idea of start low and go slow, monitor for falls, watch for postural hypotension, orthostatic hypotension, as well as other adverse events. And overall, it seems that blood pressure less than 150 over 90 is the target for many elderly patients in general, is kind of our goal. And I'm happy to take any questions if you want to email me. Thank you so much.